Hello, everybody. Welcome today to our 23rd session in the Insight 2020 Festival. What is in your decision-making toolkit? Apologies, we're running a little bit late. We had some problems with Zoom today, so we're just going to give it a minute or so while people join to kind of cover our introductions and a bit of housekeeping before we get going with our speakers for today. So this is the first session in a week where we are looking at things that you need within your local system to support you in decision making. And I've just realised I haven't introduced myself, so I will pause for a second. I'm Janine Deller. I'm a programme consultant in the strategy unit, working with systems across the Midlands around kind of establishing their decision support units and working to support the strategy unit's Decision Support Centre. Today we're going to be talking about the things that you need within your systems to support decision making, and we've got some fabulous speakers today. We've got So I'm just trying to progress slides. Jackie Chin, who's part of the Population Health Management team at NHSEI, who's going to give us some of that wider strategic context on the importance of decision making in the and the components of good decision making in the population health management agenda. We've got Dr. David Shepherd, who has been a GP and a GP trainer in Leicester City for 27 years and served on the CCG board. He has worked with Mark Pearce for a number of years now in this agenda, looking at how they can use really good linked data sets across Leicester, Leicestershire and Rutland to improve decision making. He's now working to provide analytical support in population health management to the CCG and is a senior clinical research fellow at Leicester University. Mark Pearce is also talking to us today. He's the head of population health management for Leicester, Leicestershire and Rutland. And we've also got Rob Howard today. He's a consultant in public health at Leicester City Council, and he's going to talk about some of the wider context in decision making. So some of the other things that you have to consider, the views of the patients and the public, and some of the political context around local decision making. So I'm going to pause there and hand over to Jackie while I go onto mute. And I also just need to change some slides over. Just a quick reminder of our housekeeping rules: keep your microphone muted, do introduce yourself in the chat box, and do use the chat box to ask any questions. We are recording the sessions and we will make the sessions available both to our participants and other people after the session's finished. So thank you for that, and I will just hand over to Jackie.
Thanks, Janine. Thanks, everyone. I'm so sorry. I can't get my Zoom camera on, but hopefully you can hear me. Is that all right, Janine? Can you hear?
Yes, that's fine.
Okay,
yes,
brilliant.
That's absolutely fine. Sorry, too many buttons, and I'm just trying to sort out resharing the screen. Sorry, Jackie, just give me a second.
That's fantastic. And I'm so sorry. I'd love to hear the rest of the presentation, but I will want to hear from Leicester colleagues, but I need to leave at 2:30. Brilliant. So what I'd like to do is share with you some learning from the Population Health Management Development Programme that we're running in a number of systems, and how population health management has helped with decision making. Janine, are you able to move the slides?
Hopefully people can see the slides, but yes, I can move the slides forward for you. Okay,
if you could go to, is it maybe just on my phone that the slides aren't moving?
No, I don't think
can't see
moving,
the slides.
Janine.
Yeah, thank you. Thanks, Karen.
Click on the title slide, Janine.
Brilliant. Thank you so much. Okay, thanks. I've got the first slide. That's fantastic. So, guys, colleagues, for those of you, some of you may know about the Population Health Management Development Programme, but just to recap very quickly, it's a 22-week action learning programme designed for systems, STPs and ICSs, really to try and enhance their population health management capacity and capability. And as the slide that you can see, it really works on a number of different levels. At a system level to help inform decision making at a system level, place, primary care network, and there are a number of analytical action learning sets. So there are a series of learning sets throughout the 22 weeks to put in place an intervention at the end. Next slide, please, Janine. Thanks. Brilliant. So this slide just shows you some of the approach that we take and some examples of how from a system to person and person to system, the population health management insight is used to help make decisions. And on a system level, you'll see it's helped to inform decisions around resource allocation among providers. At a place level, some systems are looking at their outpatient waiting list and thinking about how they approach that across all their primary care networks, working closely with their providers. And at a neighborhood or primary care network level, in our program, we have small PCNs drilling down into look at a small cohort of patients to develop an intervention. And some examples of those primary care networks include looking at people with a serious mental illness, or multimorbidity, or they've decided to focus on a group with frailty or a group of diabetics. But it's a really small number, and they put in place an intervention at the end of the 22 weeks. Next slide, please, Janine. Thanks. This slide just shows a little bit more about some of the insight that's used in the program. So there's economic modeling and actuarial projections at a system level to help with resource allocation. At a place level, they'll do costed segmentation and some benchmarking. Further on down at a primary care network or neighborhood level, they'll use some risk stratification really to try and narrow down on those cohorts that they want to focus on. The next slide, please, Janine. Thanks. This one just shows, just illustrates actually some of those analytical techniques that are used. You'll see on the top left-hand corner, the outputs of the actuarial modeling. Top right hand, some of the segmentation outputs, and on the bottom half of that slide, there's some risk stratification work. And the theographs are really brilliant for illustrating, I guess, that patient's journey and their experience over a period of time in their care journey. The next slide, please, Janine. Thanks. The next few slides really just give some examples from systems that have been through the program and one that's currently ongoing. So you can keep flicking, Janine. This is a Dorset Intelligence and Insight Service, and some of you may have joined the mini huddle that we held on this. They developed their dashboards, and this slide really just shows the series of dashboards that they produced. Next slide, please, Janine. And this one just, yeah, that's fine. The next one just showed some COVID-19 insights report. And the slide that you can see really shows how they use that data to help think about how they utilize their workforce and optimize it. And they really use this to help inform the way that their social prescribing team worked, including their link worker, their health coaches, the volunteers and the voluntary organizations, and how they focus and streamline that work over a period of time. The next slide, please, Janine. And this one just shows in a little bit more detail how they're using that insight to help move from reactive to proactive care, thinking about resource utilization, thinking about how they prevent escalation of care, and in particular, how they're using it to inform and monitor and evaluate any of the new ways of working that they're introducing. Next slide, please. This is the last slide from Surrey. They're partway through the program, and they decided at a place level to look at their outpatient waiting lists. And they looked at the number of patients that were under a number of specialties. And you'll see on the bottom left-hand corner, 24% of patients were under the care of 2 specialties, 9% were under the care of 3 specialties, 3% were under the care of 4 or more specialties. And that last group, they decided that's a group that they will focus on as a place, looking at those 537 people. They're working as a multidisciplinary team with the geriatrician from the provider and a number of PCN colleagues to think about what intervention they'll put in place over the duration of this program. So that's my last slide, Janine. Just to say that's hopefully given you an example of how some of the population health management insights been helping to inform some of the decision making in the systems. Happy to take any questions. Thanks, Janine.
So that's a really nice example of how the PHM development programme is working to support systems to draw together the elements of kind of good decision making, building up data and intelligence and insights, and triangulating things across the system to actually support the system in terms of those decision makers. How's it going in terms of the rounds that you've got at the moment? Has there been, what are the major challenges that the systems are facing as they do that, Jackie?
So I guess what we've found in the program is that actually, because we're all virtual now, we're actually able to host a wider group of stakeholders than we have perhaps would have had the opportunity face to face. And some of them, particularly at place, they really bring together both PCN and secondary care providers and local authority, and it gives them a chance to have space, time, an opportunity for space and time to reflect on actually priorities that they wish to focus on. And for some ICPs, that's really helping to progress that work and build their consensus as a newly formed ICP. So it's helping to inform the decision making. Does that help make sense? At PCN level, there are about 10 to 15 people joining the multidisciplinary team, and for some it's the first time they're looking at this information in this way, and they're very energized and they really enjoyed thinking through that intervention that they're going to work on for that small cohort. So, you know, decision making at different levels. Does that help?
No, that's really helpful. Yeah, no, that's really, really helpful. Thank you. There aren't any questions in the chat at the moment, so I'm going to pass over to Dr. Shepherd now.
So I'll kick off. My talk title was given to me as the importance of data in primary care decisions. But being the rebel GP that I am, you know what GPs are like, I decided to change it to the importance of curated data in primary care decisions. And so I'll take you through that. So a bit of motherhood and apple pie stuff to start off with. This is stuff you all know, but it kind of underpins what I'm going to say. So I'm just going to quickly go through it. So good decisions need good understanding of the context that you're working in. That context is apprehended through having accurate information. That information is constructed from the data that we have from primary care. And the more data is likely to be unnecessary, but it's certainly not a sufficient condition for better information. And so that data that we get must be controlled, it's got to be curated, and it's got to be interpreted in order to create useful information, which forms the basis of our good decision making. So what I'm going to do is I'm going to take it at sort of 3 levels, starting with the patient working up, which is the kind of good place to start. So with the patient in front of you, the context for decision making on clinical decisions is provided by information from the read codes that we have in our clinical records. And this means having enough of the right codes, and it means having that information rightly presented to the clinician so it's readable and usable to make decent decisions. So if you've just a silly illustration, but any idea what that is? Probably not. But as you increase the amount of codes that you get, you can begin to get better context, better understanding. This is our smiley CCG chair, Azza. Alternatively, you can get stuff like this. So this is an anonymized data I got from one particular clinical record a while back. And as you can see, there's lots and lots of data there. It's lovely. But for clinical decision making, it's absolutely useless. Because I really don't care that the patients had their pulse checked on the 23rd of September 2015. That's not relevant today. So as a clinician, if I'm presented with that, I'm going to be wanting them to come in with a stubbed toe or something, and certainly nothing complicated, because I wouldn't have a clue what to do. So it's about presenting the right data and having that right information in front of you. And so that's become a bit of a focus for us in Leicester. As we've done work using the ACG system, we've become to realise that the quality of information we're getting fed in through the population health management system is of variable quality. So, and using the modelling we've done on this, we can assign sort of estimated values for the relative quality of the coding in our practices. So this is across Leicester, Leicestershire and Rutland, 132 practices. You can see that maybe 40% of the practices coding is what I would regard as okay, between 90 and 100% of the codes they should be capturing are being captured. But maybe 60% of the practices, and there's a very long tail on this, simply aren't recording information as well as they should in order to provide good population health management, but also good patient level management information as well. And we've got 3 CCGs in LLR, and as you can see, there's quite some variation between them. So the county CCGs in east and west of Leicestershire, pretty much of a muchness, fairly good quality coding, but the city, we have a problem in that it's more variable. So one of the things that's happened in terms of developing our strategy is that is clearly if you've got 2 issues really, because you've got for clinical decision making, you can't make good clinical decisions without the complete data set. And so we've been doing quite a lot of work with our CCG and our practices and trying to develop a renewed emphasis on capturing the relevant coding and information into their records, which then feeds through into the population health management, but also feeds through into the quality of their actual record keeping for clinical face-to-face decision making. And we've developed a coding handbook and some video resources, which I've given a link there if you want to watch me talking about it, help you sleep probably. So that's the sort of clinical level, but the other level of it, that of course, that when you go up a bit, is then how do you then compare practices meaningfully when the data coming from them is of variable completeness, which brings us to the sort of next level up, which is the sort of practice in front of you. And as you all know, we've got loads of data on practice performance, but of course the proper context requires using all of that data to adjust it for the case mix and the huge variability we see between multimorbidity between different practices. And the traditional ways of doing it using averages and crude age sex adjustments, they just don't cut it really. So I'm going to give you a couple of examples of stuff coming from LLR. So this is a graph of the blue line is essentially all the observed cost per patient in secondary care for the whole year. And this is for all 132 practices we've got in Leicestershire and Rutland. As you can see, there's a huge range. So down end, on the left-hand end, we've got practices where about £100 per head. And at the other extreme, we've got practice that's nearly £1,000 per head. So we've got nearly a 10-fold variation. On here, I've put the green line, which is the kind of average, which is the kind of way we used to think about it before. So the problem with this is that how on earth do you work out variation between these practices? Is this right? Is it the right level? So what we can do using the ACG system and population health management tools, having adjusted for the coding variation we see between practices, we can get an estimate of where we think their expected cost should be. And this is the yellow line going wiggling across the middle here. So you can see that, so one of the questions, but without doing this work, you can't really tell whether your student health centres, which are the 3 student health centres down here covering Leicester City and Loughborough, you can't tell whether their £100 per head is a good or bad or expected or not expected. But with doing case mix adjustment, you can say, well, actually, they may be outliers, but actually relative to where they should be from expected, they're not that far away. And at the other end of the extreme, this is our homeless service in the city centre of Leicester, who deal with people with a combination of mental health problems and alcohol and homelessness problems and multi-medical problems. And as expected, their costs are high, but should they really be 10 times the other end? Well, when you case mix adjust them, you can see that actually, yes, on the same basis as everybody else, actually, they're not far off the expected cost. So although they're an extreme outlier, they're not actually an unexpected extreme outlier. But when you start looking at this, you start seeing other variation in the system that previously you could not detect. So for example, why is this practice expected cost so high, but his observed costs really low? Is that because this is a really efficient practice? Or is it because they're just not treating the patients they should be? And conversely, the other way around, is this practice down here, it should be a lot cheaper than apparently it is. So is it referring patients into hospital that it shouldn't be referring? What's going on? So this kind of information gives us a lot more useful information to start thinking about how we work out what the variation is between practices and squeeze out the unwarranted variation. One of the things we've put this to is in developing statistical process control charts to monitor the activity of our practices month by month, and then feeding it back to them on a monthly basis. So this is a fairly typical one. This is for emergency admissions for all emergency admissions. And as you can see, we've got the usual control limits around an SPC chart, and we've got the run rate of their emergency admissions running around sort of 30, bobbling up and down as you'd expect with this kind of chart. And we've got an average, the blue line in the middle is kind of the average over the last year. But when you add in the expected rate, which we can calculate having adjusted for case mix and for the coding, it gives you a rather new view on it. So you can see that maybe 2 years ago, this practice was kind of running around the level that you would expect them to be running at, given their case mix. But over time, the quality of their service just seems to have gradually gone off, and their emergency admission rate's gone off. And it's hard to know exactly why that is. And then, of course, at the end of the day, they tip off over the upper control limit. And this practice ran into problems with our CQ, with the CCG at one point. So you can see how this data might be useful to function as a kind of early warning sign that maybe something isn't right here, and that maybe we need some intervention, even though they've not actually breached the control limits here. So that's one practical use that we've used this for helping manage our practices. And then what about the population in front of you? And one of the things that was alluded to earlier is this idea of trying to identify new areas where we can make interventions to improve care for our patients. And one of the things we've done is looking at things called practice pairs of interest. So this is the graph that I showed earlier, but I've redrawn it, and instead of ordering it by the observed total cost, I've now ordered it by the coding adjusted expected cost per patient, which you may think, well, that's not terribly exciting, but what it does is it introduces some other interesting new possibilities for analysis. So, for example, here we've got one practice's observed costs a long way above their expected costs, having case mix adjusted it, and right next door we've got another practice where their expected cost is above their observed costs. But their expected cost is actually about the same. So these practices should be the same cost, but they're clearly very different costs. So we can begin to take this pair of practices and legitimately have a look at them and try and work out why on their total costs they're so different. And so we've been doing some work on paired practices, choosing pairs of practices like this across the spectrum to see if we can get new insights into how things are going and what actually is going on in terms of the variation between these practices, which appears to be unexplained. So these are some of the findings from the practice pair work that I did on emergency admissions work earlier this year. And we found that residual variation is frequently due to small numbers of sicker patients having very high rates of readmission. And that seemed to focus in on certain disease areas. So epilepsy, particularly diabetic medicine, suprapubic catheter management, bizarrely cropped up, and COPD. Mark and I have got a little bit of a disagreement about the reason for this, but my explanation for this is deprivation, in that the case mix adjustment system isn't adjusting for these very small numbers of very sick patients who seem to consume very high numbers, but large amounts of resource, but who tend to, because of deprivation, tend to be deposited in practices with high levels of deprivation. We also found that there's a higher incidence of acute admission episodes for the same apparent coded disease burden for some of these practices. The disease severity was higher on admission with longer lengths of stay in practices with higher admission rates for things like headache. Again, I suspect this is down to deprivation assorting patients between practices. I couldn't find, even though you can drill right back down to the individual patient level, I couldn't find convincing evidence that the unexplained variation was due to practice behaviour. I was kind of hoping to identify things that we could say, oh, that practice is doing that wrong or this wrong. I couldn't find it, which is interesting. Previous work, we've shown that some of this variation, you can even pick up coding errors in secondary care. We had one practice where one patient was being coded as having a bone marrow transplant every week for about 20 weeks, when in fact they were having outpatients appointments after one bone marrow transplant, which obviously put that practice as a very high cost inappropriately. So that's an example of the sort of information you can use. So in conclusion, sort of correctly curated and sufficient data underlies good decision making at all levels, whether it's talking about patient care or whether you're looking at practices performance or to the population level. Patient level data is the best basis to inform all levels. So you start from the bottom and work your way up. We found our experiences that works very well with clinicians like me, because essentially you're using data that relates to patients that they normally have sitting in front of them. So it makes a lot of clinical sense to them to use this kind of thinking. And we've also found that case mix analytic methods with adjustments for missing data, they're very powerful tools to create the right context for good decision making and for investigating unexplained variation. And there we are, that's it. I'll share if that's all right.
Thank you very much. We've had some good comments coming through the comments section, but I'm going to hand over to Mark now, and we will pick discussion up at the end if that's okay.
Okay.
And Mark, I'm just about to share your screen and get your slides up.
Do you mean good afternoon, everybody? It's a real pleasure for us to have the opportunity to share some of the work that we've been doing over the last several years in this space. Adjusted clinical group software gives us a range of options really for, that's not the right section.
No, it's okay, give me a second, sorry, I'm nearly there.
I did think I was going to have to talk about David's astronomy slides.
Has you got the right slide?
Yeah, there we go. Thanks. So there's just an interesting thing, I think, to add to what David has said, just to build on some of that. One of the most satisfying things I've done in my commissioning career over the last 11 years is in 2017, we used exactly the data that David has shown you to identify 8 practices in Leicester City whose observed rate of emergency admissions were significantly below their case mix adjusted expected rate. And the chief executive at the time got a group of those 8 practices out of a possible 57 together, who all shared this sort of collective character.
Sorry, Mark, sorry to interrupt. People can't hear you. Can you either adjust your headphone a little bit? But yeah, we've had a few people just saying they can't hear you, but that's better. Is that better, people?
How's that? That's good. Okay. Well, that's a shame, because I was waxing what I hoped was somewhat lyrically about the opportunities that David's work has given us on the commissioning side. In 2017, we used the data that David has shown you. It's one of the most satisfying things I've ever done, really, I think, as a commissioner, to bring together a group of 8 practices whose case mix adjusted level of observed emergency admissions was significantly lower than their expected level of...
You've gone quiet again, Mark. I don't know if your microphone keeps slipping.
Is that better now? Is that better now? Is that better now?
It's not, no, it's not where you got it great, and it's just faded out again. Let
me just see.
That's better, that's perfect.
Okay, I've taken the headset off entirely. I'll have a go. I don't know how much of that came through. A little bit of it, okay.
Most, yeah.
Okay, so what was really interesting and really very satisfying, and I do apologize it's taken me so long to get going, was bringing representatives from those 8 practices together with our chief executive and a number of the executive team. We were facilitated by one of our independent lay members, and it was an extraordinary afternoon whereby I think originally when they came into the room, they were all rather suspicious because we'd invited them in. And I think they all thought they were in trouble in some way. But once we opened up and showed the data and demonstrated actually that all the hard work they were doing was making them positive outliers, we got a really, really very interesting conversation around what they were doing differently. And we had practices, some of whom were GP teaching practices, some of whom weren't. Some of them were single-handed inner city GP practices. Some of them were extremely large GP practices in Leicester. Some of them, they were all funded more or less about the same. They were all offering more or less about the same number of appointments per head. And so it was a really interesting, quite a diverse group. And when we asked them, what do you think you're doing differently that gives you these kind of outcomes for your patients? So if you imagine that lower than expected levels of emergency admission may be a surrogate marker of better care from the patient's point of view, we got some really interesting responses. The level of attention to detail, a few themes emerged. One was about, a theme they had in common was a flat hierarchy. In different ways, but along the same theme, they all described how they deliberately and consciously put a great deal of effort in creating a sense of equality between all the staff in the practice. So one GP partner said, I'm quite happy for my receptionist to put 4 extra appointments on at the end of a busy morning surgery, because I trust that she knows our population at least as well as I do, and in some cases better. And if she thinks these people need an appointment today and I've already finished my surgery, then I'll happily see those patients or ring them back. One of the other things that arose was around attention to processes, a real attention to detail around quality of clinical coding, which is something that David has alluded to, and attention to detail around potentially ringing patients when they'd been discharged from hospital, individual GPs ringing them up. Talk me through what happened before you were admitted. Talk me through what your decision-making process was around calling an ambulance. And in an inquiring but supportive way, trying to understand if there was possibly a different solution that could be offered to the patient or carer the next time. So I have to say, although it may look to a non-technical person like me, initially slides like that can look quite daunting and they can look a little bit dry. Actually, what really interests me as a commissioner is you can turn insight derived from patient-centered data, from a patient-by-patient data set, individual patient data set. You can aggregate that, turn it into insight and analysis, and actually then go on to bring it back around to meeting those GPs. And in fact, what we did was we invested £200,000 on 2 successive years, on the 2 years following that meeting that I've described, investing in GP localities to replicate some of the good practice that we had found. I'm just going to go on to, Janine, if you would just move forward a little bit. Thank you. So I'm just very briefly going to run through a series of slides. My theme today really is around talking about how we can turn data aggregation and data analysis and data insight into commissioning action and into sort of patient outcomes. So this is data derived from the Adjusted Clinical Groups system. We're looking here at just a little bit over 400,000 records for Leicester City CCG. And of course, this shows rather what you would expect to see. This is looking at all secondary care costs, for instance, and what we see is that about 5% of the population is accounting for 65% of all of our secondary care costs. Now, I'm sure many of the people listening today will have seen slides that look like this, if not exactly like this, before. What we found, which I suspect may be a shared experience, is that showing clinicians, showing commissioners their own data, are being able to say this is Leicester data, it's 400,000 Leicester City patient records aggregated together, is really much more effective than saying this is Slough data or this is Birmingham data, good and all and correct and all as those other data sets might be. So one of the things we've found going forward is aggregating and analysing people's own data is a way of creating a common bonfire that people can all gather around and feel that they've got an interest in. Of course, we would immediately start, when I started back in 2005, when I set up a community matron team, essentially I said, right, if we can find just the top 400 people there and case manage them perfectly, what we'll do is we'll save the CCG loads of money and we'll be in the HSJ. And of course, what we understand now is that things don't work like that. lots of people understood at the time, but I didn't. In fact, because of regression to the mean, of course, we understand that a lot of those patients over a period of time will either die, they will move out of area, become somebody else's issue, or they'll go through a following period of clinical quiescence or clinical stability. And so what we've really got to do, and again, slides like this I found very useful at PCN level, very useful at sort of locality, and at CCG level, is to say what we mustn't do is imagine that all we've got to do is more perfectly identify and more accurately identify the top 1% or the top 2% highest group of patients, because although it seems like a very tempting target for investment, actually what we've got to recognize is we need to manage the whole population. If you could just move down a couple of slides, Janine, to the colored table, a little bit further, and a little bit further again, and again. So this is an interesting slide. One of the things that has emerged, as you'll see in the slide to come, but one of the key insights I think that we've gained from aggregating data, and again, it's really been what I would regard as a sort of a turnaround series of moments for the CCG from the point of view of commissioning strategy, is the impact of multimorbidity and the impact of multimorbidity throughout the population. So this is looking at 5 index conditions. I think it may not be apparent from the version of the slide you can see, but these are things like an index condition like diabetes, congestive heart failure, ischemic heart disease, obstructive pulmonary disease, and so on. And what we see is actually, given these index conditions, multimorbidity is really quite the norm. So 65% of all the congestive heart failure patients on the extreme right-hand side of your screen have got 7 or more additional long-term conditions. So this has a real implication actually in terms of what clinical services we commission. Any GP, any day of the week will say, yes, I recognize that clinical reality. The patient may present to me with increasing breathlessness and some edema that they're worried about, but actually when I open up their clinical records and when I go to try and solve the breathlessness and edema question, I really have to take into account the complexity of their comorbidities. And I have to recognize what that really means for other stakeholders involved in this patient's care, such as the patient's carer or potentially adult social care. If we just move down one slide further, Janine. Now, I always say that for me, I think this has been the most helpful slide that our CSU has derived from the adjusted clinical groups data from a strategic point of view. So this is looking at the relationship between increasing levels of multimorbidity on the vertical axis and then consumption in the previous 12 months of various aspects of NHS care. And what you see really captured in one vision is a view of the whole population, which shows that it is increasing levels of multimorbidity that are really quite closely associated with increasing levels of consumption of various healthcare resources. And in fact, it's not a linear relationship, it's an exponential relationship. So once you get beyond having 5 or more chronic conditions, you can see that your utilization of things like emergency and elective care, A&E attendances, the cost of your inpatient admissions, for example, even the number of tablets that you take every day, all of those things increase. And so there's a couple of things I would say is this is absolutely one of the things that drove the construction for us in Leicester City of a locally enhanced service offered out to GPs, which said, we want you to focus on those patients who've got 5 or more chronic conditions, plus or minus a frailty flag switched on. So the ACG system includes a frailty flag. Plus or minus predicted to cost 3 or more times the average in secondary care costs. So those were all identifiers or markers within the ACG population profiling system. And what we used was outputs such as this that you see in front of you now, really to construct an incentivization scheme for primary care. So we said we've got I think at the time it was £650,000. We wanted to incentivize GPs to select relatively high risk patients. And what we did was we used the characteristics that have been identified through this kind of data analysis to say, okay, so look for people with 5 or more chronic conditions, the frailty flag switched on, plus or minus a propensity for higher cost in secondary care terms. And then I think, again, what felt like a breakthrough was we didn't simply allocate the money between the 58 GP practices based on weighted population. What we did was we used the case, David did all the work, using the distribution of patients with these characteristics proportional to their total population, their total registered population, was the basis upon which we allocated funds for this program. And so what that meant was a very large university practice with 20,000 registered patients would be allocated fewer patients to enroll in this enhanced program of care than potentially an inner city, much smaller practice of 5,000 or 7,000 patients, which had a much greater proportion of patients with these sort of troubling or worrying characteristics, this shared propensity for harm. And so for the first time in my commissioning career, at least, we were able to make the money genuinely follow patient need in primary care. And I think one of the really useful things was that we found that the GPs didn't complain. So we were expecting and rather girding ourselves for a tidal wave of complaints and pushbacks from the LMC and so forth about this being unfair. And in fact, because we had explained the rationale and road tested this model with GPs, actually we found that there was simply no pushback. People recognized, because it was derived from their own data. So this is all based on individual coded consultations in primary care, and then that data being utilized. The other thing I always say about this slide is, you know, when we look as an ICS or when we look as a whole CCG, do we have a strategic plan for how we're going to manage the healthcare needs of the patients in the upper tier, the green zone, who've got relatively few multimorbidities, who are relatively still well? Have we got a strategic plan for how we're going to manage those people at the other end? And of course, this has been a really useful slide for us for the Better Care Fund, because one of the implications for patients with, say, 6 or more chronic illnesses is we can easily describe, in terms that our local authority colleagues understand, that one of the implications of increasing levels of multimorbidity is increasing levels of disability. So difficulty in completing activities of daily living, largely leading to sort of a greater propensity to need local government or adult social care support. And so we were able to use this slide, I think, to start a conversation at BCF level around how we could use the joint pool that is BCF funding to commission a suite of services, everything from assistive technology to fold services to some voluntary sector services, which really would add up to a person-centered, holistic suite of services that could be wrapped around that patient group who've got 6 or more chronic conditions. So this has been very helpful. The other thing, of course, to say is that David has alluded previously to issues around how there are, you know, how do we deal with, how do we talk about in a non-judgmental, non-negative way about variation in healthcare outcomes. And of course, one of the interesting things to look at would be if we were to drill into one of these cells here, let's say the cell for patients with 4 or more chronic conditions, we see that the mean cost for their inpatient care is £664.20. And of course, within that, that means there'll be there'll be about half the number of patients who will have costs much greater than that, half the number of patients who will have lower costs than that. And so looking within that cell may give us some hints around what may be some variation in care that we feel we want to do something about. If you just move on one further slide, Jane.
Yeah, Mark, can I give you a minute warning?
That's absolutely fine. The other thing that we realized in looking at these data, and if you just click twice more, I think. The other thing we realized looking at these data was that, sorry, go back up one, Janine. thank you, is we realized that we couldn't afford to focus on only the over 65. So when I started first with this, I remember sitting in a room full of GPs who said, look, all this risk stratification stuff is really fine as far as it goes. But quite frankly, if we're going to start somewhere, let's just surely start with the over 65s. One of the things that this slide allowed us to do was really to challenge that idea. So this is a 5x5 matrix showing 5 cohorts of increasing age and then 5 groupings of increasing levels of multimorbidity. And I don't know if it's visible on your screen, but what you ought to be able to see is that those people aged 18 to 44 with 8 or more chronic conditions in the ACG system have got mean emergency costs, which are significantly higher than any other age group, including those people aged over 80. So this just illustrates the point that multimorbidity is distributed right throughout the population. It's not the preserve of older people. Multimorbidity, more than any other single driver, is driving activity into secondary care. And in fact, understanding that there are younger cohorts of patients who are highly comorbid is a really good platform for talking to voluntary sector colleagues, talking to local authority colleagues about how we can work together to improve and support not just the care of those individuals, but the support for carers, the support for children in those families around educational attainment and so on. So I'm going to stop there because I have to.
Thank you very much, Mark. I do think it's just so kind of, I know it's been a long journey in Leicester, but you've actually got to the point now where you are actually driving forward change and understanding all of the kind of components of things that drive the need for healthcare and actually start to develop solutions to meet the needs of people. And I love the idea that the money is following the need, and that's what we've all been trying to do for a number of years. And I'm guessing just in terms of the identified need and health inequalities, there will be an underlying build that kind of maps deprivation through to driving some of the multimorbidity as well. So it just feels really positive. But I'm going to hand over very quickly to Rob, who's going to bring in some other perspectives on decision making now, and actually thinking about some of the things outside of data that we need to think about when we're making informed decisions for our populations.
Great. Good afternoon, everyone. So yeah, I'm going to do something, it's a bit different from the previous ones, which were kind of more about the data and intelligence. This is probably a bit more about, so what do you do about it then, and how are those decisions made? So I'm consultant in public health now at Leicester City Council. I was previously at Leicestershire County Council for a number of years. I'm also the head of school for the public health training programme for the East Midlands. So in some ways I can abstract both in terms of my own training, but also from the perspective of the head of school. It's quite good to look at the difference between the theory about understanding data, evidence-based decision makings, hierarchy of evidence, and then the actual practice of what happens when you land in a local authority. And the two are very, very different. So I was thinking about this, and really what I'm talking about here is some of the human factors around decision making and some of the problems that exist around evidence-based practice. So I was thinking about this because a couple of weeks ago I give a lecture for the Masters in Public Health students at the University of Nottingham, and I do a lecture around health impact assessment, which is primarily around how do we influence those wider determinants of health, major infrastructure projects or major policies and so on. How do we influence those to create environments where it promotes health and mitigates against potential harm? And as part of that lecture, we look at what constitutes evidence. So we talk a bit about developing community profiles and the data aspects of it, but we also talk about the policy context for whatever the infrastructure is and the decisions that have to be made. Really, really important. We talk about the standard literature reviews to generate evidence base. And then finally, we talk a bit about stakeholder views and expert views. And so as part of the illustration for this, I come up with a theoretical situation where a telephone company wants to put up a telephone mast in a primary school. And then divide this group of 40 MPH students, and half of them have to pretend to be public health experts, and they get to do a quick literature review on the latest Public Health England evidence related to mobile phone technology and health. And then the other half pretend to be parents of kids in a junior school, and they get access to things like, you know, the headlines in the Daily Mirror or the Daily Mail or whatever, and then they have to have a debate as though they're in a public environment and a public hearing, and at the end of it we have a big vote on it. And I've been doing this for about 6 years, and not once have the public health experts won the vote. Not once. And it's maybe not surprising then it's part of the kind of the game for it, but I think it also illustrates a really important point, that we can go around and we can do our really intellectual objective analysis around the data, around the evidence, but that's not what happens in practice, because in practice decisions are made for all sorts of reasons. Some of them, and I think the reasons that the public, the parents, people pretending to be the parents as children, win this argument is partly because of the emotion and the passion that they bring to their arguments, and they're just much more entertaining. But it's also something around fear and trust. Trust in government, trust in local bodies, trust in professionals to make the right decisions. And there is a lot of distrust out there, and I think that's increasing. And it's also perceptions of fear, which people are notoriously bad at understanding risk as well. And then when you think a bit more about it, I think you can also think it's not just a case of the public getting it wrong. It's actually a case of professionals not understanding the public and the public view until you put yourself into that situation and you're in that in your real life, or you're playing a particular role, because then different things come to the fore as well. So it might be, well, what's in it for these parents to have a phone mast on their school? You know, if the school getting much money for it, probably not a great deal. There is some risk, you know, there's uncertainty in making that decision. What's in it for them other than they're seeing a big corporation putting their children at risk for their own profits? So then it starts getting quite political. And so these decisions always take place in a much wider context than the purity that we've seen in the discussion so far. So I wanted to think about the hierarchy of evidence that we use in terms of making decisions, as well as looking at obviously the data. We use a hierarchy of evidence from systematic reviews and randomized control trials. I'm thinking about that in order to make the best evidence-based decisions on the best available evidence. And there are real problems with that. And partly is that the limitations of those hierarchy of evidence. So randomized control trials are only done for certain treatments. There's lots of stuff that you can't do randomized control trials for. They're normally done with a very unusual sample. So often you will be excluding people with comorbidities, for example. So exactly what we've been talking about, the people that we want to actually put in some evidence-based solutions for are the very people who are excluded from randomized controlled trials because it'll cloudy the evidence for that academic kind of piece of work. So there's limitations around that. There's limitations related to publication bias. They take a long time, and they're often, when we're in practice, when you're trying to decide what to do in a local authority environment. For example, COVID right now, there isn't much evidence, and we need something really, really quick. And RCTs and systematic reviews aren't really very good. They're quite often out of date as soon as they've been published. And there are a number of factors that a lot of this that kind of traditional academic approach misses. So one of them we've alluded to is the politics, and in a local authority we work in a very overtly political organisation, and the councillors and the members who are responsible for making decisions about what we do and don't do are the legitimate representatives of their communities, and they know and understand their communities in a very different way than we might know and understand our communities from understanding the intelligence and the data that we get through. But it doesn't mean that their understanding is less legitimate. It's very different, and we need to work out ways of understanding that and having those negotiations for it. So for example, at the moment I'm trying to get more work done on air quality in the city, and we're looking at various interventions for that. But politically, there's a bit of a bum fight between the responsible councillor who's responsible for public health and the councillor who's responsible for the environment. And the one that's responsible for public health thinks that all the environmental climate change stuff is a load of nonsense for middle class sort of people in very restricted areas of the city. And actually the most important bit is, what is the impact of poor air quality on health? And also mental health and well-being. So you get involved in all these sort of different debates, and you have to negotiate your way through those sort of discussions. Politics is absolutely crucial, and I wouldn't want to delegitimize it, but it's the reality of where decisions are made. The other thing I think is understanding the perception of the patient or the public in this as well. Because it's not just about what works and what's cost effective, it's also about what is acceptable, what relates to that person's understanding of themselves, their values, their preferences, and also what is just completely acceptable. So if you think about something like bowel screening, for example, and it's always been incredibly low take up because it's just deemed to be not acceptable to people. So I think the final bit, as well as thinking about effectiveness and cost effectiveness and the right solutions, it's also thinking about the affordability of the various stakeholders and organisations that are involved, because we could have very good evidence base for something. It's very cost effective in that theoretical cost per quality model that we might be looking at, but we haven't got the money to do it because it's maybe something for a huge number of people, even though it's very, very small cost individually. So there's the final bit I wanted to mention was also most things that we'd want to do when you do a systematic review would say there's no evidence of effectiveness. And that's very different from saying there is evidence that there is no effect. And that's probably the majority of things that we'd want to do is because they're not, particularly in a local authority public health improvement situation, and particularly in a wider determinant setting, there isn't that academic evidence base. So a lot of this is about a judgment call and about working from first principles rather than having the evidence laid out. So I'm going to finish there, but just think about overall, it's an extremely complex situation, and we have to grasp that complexity and face it and discuss these different competing interests and discussions around the politics, around public's understanding, around the public's preferences, so that we have a really better understanding of their kind of experiential evidence as well as the academic evidence. And I'll leave it there.
Thank you very much, Rob. We have run over by a few minutes and a few people have dropped off because they've got other things to go to. So apologies to everybody. A combination of my bad sharing and the issues we had getting people online with Zoom at the start. I'm happy to carry on for a few minutes, and it looks like people are staying with us. So if you've got any, we've got quite a lot of conversation points that have come through in the discussion, but if anybody's got any other questions, please do ask them. I think for me, good decision making, changing the culture towards making evidence-based decisions in organisations is really complex. It's really complex without all the things that Rob's thrown into the mix, which add a whole other dimension to it. But the kind of triangulation of data, getting data to be good enough quality to make decisions on, having the right skills to do all of that data linkage and join it all together and turn that into insights that people can use to make decisions, selling those decisions to GPs and bringing them along with you, selling them to the money people in the CCGs to make the money follow it. But then at the other end of that, actually making those decisions palatable to members of the public and politicians so that actually they will support what you're trying to do is really significant. And actually how we do that systematically throughout our systems, throughout our emerging ICSs, will be things that we'll be grappling with for the next few years, I'm sure. Karen was very enthusiastic about seeing statistical process control and the idea of the paired practices and how that worked, and actually using the use of variation to learn from what was going on in practices. So that would be a nice one to follow up at some point. And the kind of the practice of pairing practices. So actually, how did the pairing practices work? Do they? And I'm assuming by pairing practices you can actually have some really robust clinical conversations between the two sets of practices around what's different and how they work together. Oh, Fraser has kind of thrown one in here that says we're very good at constructing after the event explanations for things. So he's wondered about whether you've asked practices to predict and explain when they think they would be on a given measure before they see the analysis. So again, that's another one for Dave if he wants to come in and answer some of these.
Yeah, I mean, yes, certainly it's certainly possible to construct all kinds of explanations when you start looking at these SPC charts. One of the things we've found is that yes, that sometimes happens, and particularly if people are engaged, are feeling a little bit defensive, they will tend to come up with the explanations that make them look the best or don't look so bad. But one of the things we found with it is that if your data is really good, actually what it triggers is a recognition of what's going on and an acceptance of what's going on, rather than a construction that is an interpretation that might not be the truth. So yeah, you're right, and I think we're back to where Rob's been, isn't it? It's understanding these discussions and taking people with you in those discussions so that they feel confident that this discussion is trying to uncover what's really going on, rather than trying to find an explanation that makes you look good or not so bad. And certainly when I present this data, generally, initially I strip off all the patient identifiers, or the practice identifiers, when presenting to practices as a group or at a PCN or something, simply because inevitably people will their mind immediately goes to their practice to see what's going on. So we strip off those identifiers initially for the initial discussion so that people can actually think about it a bit more objectively. And that's quite helpful doing that.
No, that's really helpful. I'm going to pick up one last question, and I think all of you can come in and help to answer this. It would be really good to get a quick perspective from each of you. And it came in for Rob, but it's what sort of softer skills do you think we need our analytical colleagues to develop to better influence strategic decision making? So taking into account everything that you've talked about today, the people at the bottom that are building the data and building the evidence, what is the development direction that we need to take them in so that they're actually supporting this process all the way through?
I'll come in first if you like. It's directed at me. I'm not sure if it's specifically for the intelligence kind of community, but I probably would say if you look at it from an academic point of view, that psychology and sociology are probably just as important as epidemiology. And actually, from a personal point of view, I would say obviously it's communication skills, but it's also having a sense of humility as well. And I think there is a danger of having the purist look at data and you think, well, it's obvious what the answer is. You can see the statistical process control charts here. It's clearly there, without actually understanding any of the cultural or psychological factors that are coming to play on why there is that variation, and thinking not just about identifying the problem, but how you're then going to implement the solution to it, is as much about taking those factors into account.
It's also about developing the right culture in the organisation so that kind of conversation can take place. And that's one of the things one of the things we noticed in the practices that Mark alluded to earlier was that they had a kind of open culture where people felt that they could, you know, if the receptionist felt there was something not right, that wasn't working properly, they felt able to say it to the GP, and then the GP go, oh crikey, we better sort that out. And so they actually did, they did sort out, you know, so their customer service, if you like, was much better. And that then generates a sort of positive virtuous circle, because then the patients trust you, and then the system kind of works better, and everyone feels more confident with what's going on. So there is a real leadership and a cultural issue here that that came out some of our analysis of the data that Mark alluded to earlier.
Thank you, Dave. Mark, is there anything you want to add from a more managerial perspective on that one?
I don't think it's new. I think Rob and David have both alluded to the important softer skills that I think are really essential here. The spreadsheet or the slide set is only the start of it. And I think what people in my position need is they need support, quite often from clinical colleagues. Actually, they need support to develop a way of looking at this, which is both humble and questioning. And I've often been struck by the fact that if you share this data in a humble and questioning way, other clinicians or other people in the system, including people who don't belong in the NHS, who don't have a role in the NHS, actually can help you find answers. And I've found that really humbling, but also very exciting. So I would encourage my analytics colleagues to see their job not as finished when they've completed the data collation and so forth, but to stay with the process beyond that so we can all learn together.
Yeah, I'd
Brilliant.
absolutely reinforce that. I'm always surprised by what turns up for an explanation which you completely weren't expecting. And if you just keep quiet and let other people do the talking, very often you learn stuff really useful.
Brilliant. Thank you, everybody. Can I just say a massive thank you to all of our speakers. I think it's been a great start to our kind of thinking through decision support and the components that we need for decision making. Just a quick plug for the events that we've got throughout the rest of the week. On Wednesday, we've got 3 sessions. We're talking about our Decision Support Unit Education and Development Programme at 10 o'clock. At 2:30, we've got a crossover event with the NHSR conference, which starts in a couple of weeks, talking about why the NHS should use R. And later on in the afternoon, we are talking about the NHS as an anchor institute and sharing experience and shaping decisions. So 3 really good sessions to look forward to on Wednesday. Thursday, we're talking about making sense of the emerging COVID-19 evidence base. And on Friday, we've got a session that is looking at decision quality. And actually, Rob, it would be fantastic if you could join us for the conversation about decision quality, because if there isn't political appetite, it's another dimension to kind of add into that conversation that would be really helpful. So a massive thank you again to all of our speakers, an apology to our participants for running over, but I will wrap this up now and let you all go off to the rest of your day. And thank you very much to Jackie, David, Mark and Rob for coming along and giving us such interesting, informative sessions today. Thank you.